After a great response to Truwellth's diabetes management series covering nutrition and diet, Dr. Anil Bhoraskar systematically presents the treatment options for managing diabetes. Dr. Anil Bhoraskar has completed his MD from Grant Medical College, Mumbai in 1980 and has been recently awarded the Fellowship of Royal College of London. In his 4 decades of diabetes practice, he has treated over lakhs of patients with diligence. Treatment of diabetes being Dr. Anil Bhoraskar's forte, this episode is a must watch to understand what drugs can be appropriate in management of diabetes. We are fortunate to be able to pick pearls of wisdom from this huge personality. Truwellth is most proud to bring to you this episode as Truwellth believes in separating science from hype and bringing authentic nutrition and healthcare information to your fingertips. Please remember, this episode presents the doctor's experience for better understanding and management of the disease. However, no treatment should be taken without proper advice from a physician or healthcare professional. You can feel free to reach out to Truwellth for taking advice from these stalwart doctors and nutrition experts. Over to Dr. Anil Bhoraskar.
We have discussed the oral drugs. Now one should realize the reason I'm going to conclude this. It is very unfortunate that I have to see many of my patients and many of my students who have been trained by me and in practice, intelligent boys and girls of course, and intelligent hard-working students, they tend to follow a particular pattern of prescription which I feel at times is controlled by pharmaceutical companies. Sorry, I have very firm opinions about certain method of prescription manipulation by the companies, particularly of young doctors. And I see sometimes in a patient whose fasting sugar is 150, post-lunch is 190, 200, HbA1c more than 8.5, for more than 4 years, mild proteinuria, still on 5 different drugs. The prescription contains metformin, sulfonylurea, DP4 inhibitor, alpha glucosidase inhibitor, and SGLT2 inhibitor. And yet the patient is not put on insulin. Now this is very surprising. I have luckily good relations with all my young colleagues and students, and I pick up a phone and I ask them, why did you do this? I mean, why did you not put him on insulin? He says, sir, I agree, I should have started on insulin, but the patient's resistance for insulin is so severe that I thought that I will lose this patient and he'll go somewhere else. I say, in a way, it would have been good if he had gone somewhere else, because at least you will not get the blame for developing complication in this patient. Let him go if he doesn't want to take a scientifically right advice. But, in my opinion, when more than 2 or 3 drugs are going for more than 10, 12 years, HbA1c more than 140 on 3 occasions, HbA1c, fasting blood sugar more than 143 occasions, HbA1c more than 8.5 is an indication to put your foot down and tell the patient, my dear friend, you need insulin now. At the most, what he will do, he says, I don't want to take treatment from him. Fine. It is better not to treat a patient who is averse to scientific advice than to give him a wrong treatment. In my opinion, if you do not start insulin in a right time in a patient, it is unethical and it is a wrong treatment. Now, you'll realize what is the first barrier of this insulin therapy. The first barrier is in the minds of doctors. It is in the minds of doctors. They don't want to start it for various reasons. Because insulin means a different disciplined life, timing of meal, timing of injection. Now, luckily, the injection techniques have improved so much. The insulin delivery systems have also become so painless that the phobia of needle is also gone. Virtually, the injections are pain-free and they are very convenient. They are expensive. I'm not saying they are cheap medications, but that's the right treatment. So this barrier is first barrier is the doctors. We will have to train our diabetologists as well as physicians to put the insulin at the right time. Do not delay it. If you delay it, you will end up in trouble. Then you have to treat the patient with insulin in a proper way. That means it needs monitoring. It means adhering to meal timing. It means adhering to caloric load. It means taking insulin appropriate dose, and also look for possible side effects of hypoglycemia, and to understand the relationship between the so many oral drugs and insulin in the combination therapy, advantages, disadvantages, possible dangers. All that needs to be studied, and you need to spend a lot of time with each patient when you put the patient on insulin. You cannot just write it on a prescription and say you start it. No. It needs a lot of understanding. It needs a lot of training. It needs a lot of convincing. It needs a lot of showing how they can go wrong, what are the hypoglycemia, what are the early signs and symptoms, and what care you can take at home, what precautions you can do, accustomed, unaccustomed exercise, omission of medication, omission of meal, delay in meal, all these things need to be discussed with the patient. It's a time-consuming affair. There are some people who don't have that much time. Then you can ask somebody, diabetes educator, to spend time, because the time spent on educating a patient on insulin and insulin technique is worth it, because it can avoid many problems. Now what has happened, there are many insulins available. There are conventional insulins, which are genetically recombinant, which are either co-formulation of mixtures. Mixtures are plain, simple, short-acting insulin and an intermediate-acting insulin. And they are very freely available, and they are very popular and very effective. Now there are obviously, because of competition and the new drugs and the new formulation, people feel that this insulin is better than this. They're analogs. Analogs are a genetically recombinant manipulation of some amino acids, and they have been made to act very quickly. They are known as fast-acting and ultra-fast-acting insulins. And they are to be given just prior to meal or along with the meal. The advantage of these analogs, that in case the patient has forgotten to take it before meal, he can take it after meal also. And particularly during surgical practices, we like to use this short-acting insulin, because the chances of late onset hypoglycemia is least with this injection, and therefore we use this short-acting insulins. There are many examples of that. The trade names, that's why I don't take the name trade names in this program. But they are very popular and they are easily available, and they are in a very easily compliant kind of a device in the form of a pen with a 31 gauge needle, which the pain of that needle is even not there. the sting of the mosquito is much bigger than the needle. I have given this injection to a 4 and 5-year-old child in my hospital and they don't even wake up in the sleep. So they are virtually painless. So the pain factor, which is a phobia and also a deterring factor for insulin, is not there and can be easily carried when you are traveling. It needs a temperature, cool temperature of 2 to 8 degrees, so you carry in an ice bag or keep it in the refrigerator all the time. And if you maintain the cool chain, the insulins don't get degraded, they don't lose their potency, and they're quite good. So one has to find that this is a convenient way of treating your diabetes rather than using 4 or 5 drugs and not able to bring down the sugar at desired level, to delay the complications and to avoid the complication altogether. People who take insulin, they live longer. Only problem with insulin, like sulfonylurea, is weight gain. When you take insulin, you feel well. There's something known as hyperglycemic malaise. A diabetic patient who is continuously losing sugar is miserable. His body aches, he's losing weight, his muscle mass is reduced. After all, insulin is an anabolic hormone. It makes you gain weight. It makes you gain weight in a positive nitrogen balance. You gain weight in form of muscles. And there is something called a feel-good factor. Patients put on insulin within 8 days, they feel, doctor, I'm feeling so well. And this immediate change makes them very compliant and they keep on sticking to this insulin and they are quite all right later on. Only problem is the treating physician must put their foot down, and when they feel that it is too much, the patient needs to change his line of treatment and he needs insulin, he should not hesitate to put a patient on insulin, and a patient should become more open for this suggestion and accept it as a way of life. This is very difficult at times because people don't like that. Are like any injectable. One is this meticulousness, people trying to save money by using the same needle 4 or 5 times. That's a source of infection. Quality of needle, quality of insulin, not storing the insulin at a proper recommended temperature. These are the problems which will lead to complications of treatment. But if this is followed meticulously, people don't have complications and they live a very comfortable life. People on insulin will look a lot healthier, they can exercise better, they don't feel tired, they don't feel run down, they sleep well, and if they can manage the weight part by reducing caloric optimally and not taking too much calorie. Many times what happens, because of fear of hypoglycemia, you tend to overeat after you take insulin. So optimize the calories and optimize the dose. It is better to start a smaller dose than to reach the straight away normal dose. Go by 2 units rise, but do not increase your caloric intake. If you do that, then you don't gain weight. Part of the weight gain because of insulin is in the water retention. Because when you're passing a lot of urine due to sugar, you lose a lot of water. And people who are on insulin should be particularly very careful to avoid salty food stuff. To cut down on the salt, because the salt retention with insulin is high, they can actually develop cardiac failure if they have a tendency for a heart not to pump adequately. And therefore, salt restriction is a must. Like all diabetics, particularly people on insulin must observe salt restriction. With insulin, you live longer, you look happy, your complexion improves, your hair loss is prevented. And in particular, we've seen the young girls who are put on insulin, where they get a receding hairline, actually it stops. Their complexion improves their skin quality changes, and their bone pain also comes down. So insulin has a lot of beneficial. Besides anti-hyperglycemic, it has got many other properties. It's an anti-inflammatory compound. It has got a lot of positive findings in many therapeutic programs that insulin makes you feel well, and therefore one should not delay use of insulin. Of course, you have to take complete help of your doctor, and you have to spend time understanding the biokinetics of insulin, the time action profiles of various insulins, what time is the peak action, what time is the plateau, when you are likely to develop hypoglycemia in the middle of the night, how to prevent that. All these things you must take help of your family doctor or a physician or a diabetes educator before you take an independent role as a self-care man for your diabetes program with insulin therapy. Then you will have no complications and you will live a very comfortable life. Thank you very much for all this program that you have listened to me carefully, and probably I'm sure this will help you in definitely helping in bringing down your blood sugar as well as HbA1c and feel well in spite of having diabetes. Thank you.